The next highlight is on 2022 guidelines for the management of heart failure given by American Heart Association and American College of Cardiology. The first take-home message was that the guideline-directed medical therapy for heart failure with reduced ejection fraction now includes four medication classes. The first, the renin-angiotensin system inhibition, which include ARNi, ACEi inhibitors, and ARB alone. The second class is the beta blockers. The third is the mineralocorticoid receptor antagonist, that is MRA, and the fourth class being the new group SGLT2 inhibitors. The second take-home message was that the mildly reduced left ventricular ejection fraction has new medication recommendation to include SGLT2 inhibitors, while weaker recommendations were made for ARNi, ACEi, ARBs, MRA, and beta blockers in this population. The third take-home message was that the preserved left ventricular ejection fraction now includes SGLT2 inhibitors, while weaker recommendations for MRA and ARNi was made in this population. Several previous recommendations have also been renewed, including treatment for hypertension, treatment of atrial fibrillation, use of ARBs, and avoidance of routine use of nitrates or phosphodiesterase 5 inhibitors in this population. The fourth take-home message was that the improved left ventricular ejection fraction is used to prefer to those with previous heart failure with reduced ejection fraction and who has now have LVEF of more than 40%. These patients should continue their heart failure with reduced ejection fraction treatment. The fifth take-home message was that value statements have been created for many treatments. In accordance with American College of Cardiology or the American Heart Association, this methodology value statements were created for select recommendations where high-quality, cost-effectiveness studies of the interventions have been published. High-value therapies include ARNi, ACEi, ARB, beta blockers, MRA, implantable cardioverter defibrillators, and cardiac resynchronization therapy. Intermediate value therapies include SGLT2 inhibitors and cardiac transplantation. The only therapy identified as low value was tafamidis for cardiac amyloidosis. The value of mechanical circulatory support and pulmonary pressure monitoring was considered uncertain. The sixth take-home message was that amyloid heart disease have new recommendations for treatment. In patients with clinical suspicion for cardiac amyloidosis, screening for serum and urine monoclonal light chains with serum and urine immunofixation electrophoresis and serum-free light chains were recommended. If there is no evidences, bone scintigraphy is recommended to confirm the presence of trans-threatening cardiac amyloidosis. Trans-threatened tetramer stabilizer therapy, that is tafamidis, is recommended in select patients with mild type or variant trans-threatened cardiac amyloidosis. Anticoagulation is reasonable treatment strategy to reduce the risk of stroke in patients with cardiac amyloidosis and atrial fibrillation. The seventh take-home message was that the signs and symptoms of heart failure are non-specific and thus a diagnosis of heart failure requires supporting evidence. Increased cardiac filling pressures is a feature of heart failure, and this is assumed for patients with left ventricular ejection fraction of less than 40%. However, if the left ventricular ejection fraction is 41 to 49%, that is mildly reduced, or more than 50%, that is preserved, evidence of spontaneous or provocable increased LV filling pressure is needed to confirm the diagnosis of heart failure. In such case, evidence for increased filling pressures can be obtained from non-invasive, that is, natriuretic peptide diastolic functions on imaging, or through invasive testing, that is, hemodynamic measurements. The eighth take-home message was that the patients with advanced heart failure should be referred to an advanced heart failure center where teams specializing in heart failure are present to review the heart failure management, assess suitability for advanced heart failure therapies, and use of palliative care. The ninth take-home message was that primary prevention is important for those at risk for heart failure, that is stage A, or pre-heart failure, that is stage B. Stages of heart failure were revised to emphasize the new terminology of at risk for heart failure for stage A and pre-heart failure for stage B. Nephritic peptide biomarker-based screening followed by team-based care, including cardiovascular specialists, can be useful to prevent the development of left ventricular dysfunction or new onset of heart failure. The tenth message was that the specific treatment recommendations are provided for patients with heart failure and certain comorbidities. The recommendations are provided for select patients with heart failure and iron deficiency, anemia, hypertension, sleep disorders, type 2 diabetes, atrial fibrillation, coronary artery disease, and malignancy. Thank you.